Okay, so I just want to do a quick video of this post-infectious brainstem encephalitis associated with SARS-CoV-2. So are you worried that there's a lot of neurological complications that might happen even after the virus has left your body, or even after your body has been able to fight off the virus? So here we have an example of a woman who had brainstem encephalitis. So I think there should be encephalitis is inflammation of the brain, and the brainstem, being a part of the brain, can also experience this encephalitis. And so there are worries that, and just know that this is inflammation of the brainstem. So there are worries that this is being caused by an autoimmune response that has been exacerbated by SARS-CoV-2, possibly through mimicry. So remember, different coronaviruses have been implicated in causing these autoimmune diseases against the myelin sheath of the neurons, which the myelin sheath is the protective coating of the axons of the nerves. So let's go through this, and hopefully I can get through this quickly. So the immune-mediated neurological sequelae, so the sequelae, think of sequels, so these are the complications that arise as a sequel or after the original disease. So immune-mediated means that the immune system is responsible for these problems. So immune-mediated neurological sequelae following infection with SARS-CoV-2 are becoming increasingly evident and can affect both the peripheral and central nervous system. So the central nervous system is in the center, or it's the beginning of the nervous system, and the periphery are these peripheral nerves that are coming off of the central nervous system. So we report post-infectious meaning after the infection, brainstem syndrome in a patient with COVID-19 who presented with generalized myoclonus ocular flutter. So let's look at what myoclonus means. So this is a brief, involuntary, irregular twitching, right? So this is twitching that is going on, and it's irregular. So this woman had this myoclonus, and they had ocular fluttering, which would be when you're, how to phrase that? You know what, I might as well just get the Wikipedia article up. So is a opsoclonic disorder resulting in horizontal saccades. I don't know exactly what that means. So a quick simultaneous movement of both eyes between two or more phases of fixation in the same direction. So it's probably the eyes are just shifting back and forth really quickly. So it is often caused by damage to the brainstem, paramedian point reticular formation cells, or the cerebellar neurons controlling those cells. So in this particular woman, her brainstem was inflamed, right? And they had with convergent spasm and acquired hyperreplexia. So I don't know what hyperreplexia is, so let's look this up real quick. And remember, they said this is acquired hyperreplexia, so this isn't something that they were born with. So it's a very rare neurological disorder, classically characterized by the pronounced startle response or tactile acoustic stimuli and hypertonia. So let me see, signs and symptoms. The three main signs of hyperplexia are generalized stiffness, excessive startle. So they get startled easily, and here they're talking about beginning at birth, but this woman had it acquired, so this is something that happened later in life. So this isn't a genetic form of it, this is a acquired form of it. So let's continue. So clinical improvement was seen following corticosteroids, highlighting this as a possible treatment in patients where post-COVID-19 autoimmune encephalitis is suspected. So they are suspecting that this is a autoimmune problem, not a virus problem. So a 65-year-old woman presented with 1 week history of widespread involuntary movements, diplopia, which I don't know exactly what that, so simultaneous perception, okay, so she couldn't see, like she had double vision, diplopia, so that's a good thing to know. And cognitive decline, having experienced fever, cough, and myalgias the week before, and myalgia would be pain in the muscles, muscle aches. So she had a medical history of presumed Alzheimer's disease, osteoarthritis, and gastroesophageal reflux disease. And I believe this would be acid reflux or acid reflux. Let me double check. A digestive disorder that occurs when acidic stomach juices back up from the stomach into the esophagus, so GERD. Okay, so yeah, this would be a form of acid getting up into the esophagus. So the diagnosis of Alzheimer's disease has been made 3 years earlier on the basis of a 12-month history of amnesic symptoms, including repetitive questioning and navigational difficulties. At her functional baseline, she could mobilize unaided, leave the house independently, and wash without assistance. So she was very high functioning. So even though she had Alzheimer's, it was still in the very early stages. She just had some issues with remembering things, but she was still a functioning human being. So keep this in mind. This may have been a pre-existing condition, but she was still able. She was still able to go about her life. So don't think that, oh, someone has Alzheimer's, therefore this was just attacking someone with pre-existing conditions. That you should not think that way. You should think this person had a pre-existing condition, but they were still able to live a happy, healthy life for the time being, and it was disrupted by this virus. So, and she was able to watch without assistance. So she was fluent in English, but her native language was Arabic. Mini mental state examination scored 8 months prior to presentation was 20 out of 24. So this is just a way to quantify your mental state. So let me see. Is a test. It's a 30-point questionnaire that is used extensively in clinical and research settings to measure cognitive impairments, and is commonly used in medicine and allied health to screen for dementia. It is also used to estimate the severity and progression of cognitive impairments and to follow the course of cognitive changes in an individual over time. So it's a way to quantify someone's disease progression, which is very important. So the MMSE purpose has been not on its own to provide a diagnosis for any particular nosological entity. And the branch, I don't know exactly what this means, but oh, diseases. So yeah, it's a disease, the study of diseases. So, and the regular medications included a ribostigmine patch, 4.6 milligrams for 24 hours, omeprazole, and sulfanicin. So this collateral information from her son reported that 2 weeks prior to the presentation, she had developed non-productive cough, fever, and myalgias. She had also experienced 2 days of diarrhea, which spontaneously resolved. Her son suffered from similar symptoms. So, actually, oh, I don't have access to the rest of the, oh, do I? Okay, sorry, So although the symptoms gradually improved 7 days later, oh, and both members of the household self-isolated for suspected COVID-19. So although these symptoms gradually improved, 7 days later she developed involuntary movements, initially on the right hand and upper arm. Over the next 48 hours, these movements became unremitting and generalized, involving the face and all 4 limbs. So this involuntary movements just kept on progressing, or was neurodegenerative. It kept on going. So she began to only speak in her native Arabic before developing progressive speaking difficulties and increasing confusion. So basically she was forgetting English, or forgetting the ability to speak English. So over this time, she also described worsening vision with difficulty reading, struggling to focus, and intermittent double vision. So in the 24 hours prior to admission, she experienced a well-formed visual hallucination. So remember, I was talking about this a little bit earlier, about how there might be a monoamine oxidase interaction between the spike protein of the SARS-CoV-2 coronavirus and the monoamine oxidases, which could cause a dysregulation of these monoamines, which are neurotransmitters that can, if they get dysregulated, you could experience hallucinations and psychosis, right? Anyways, she experienced these well-formed visual hallucinations of people in the house and seeing objects flying around the room, prompting attendance to the hospital. So The most prominent feature of neurological examination was widespread stimulus-sensitive myoclonus involving the tongue and all four limbs, associated with hyperreflexia without habituation to tactile, visual, and auditory stimuli. So this would be the being overly reactionary, right? So overly stimulated, and without habituation. So it wasn't able to. She wasn't able to get rid of it after repeated. I think habituation is when they repeat a stimulus over and over again, hoping that after repeating it, you end up becoming desensitized to that. But let me look this up. In psychology, the diminishing of a physiological or emotional response to a frequently repeated stimulus. So yeah, she was given that stimulus over and over again, and it didn't go away, or it wasn't decreasing in intensity. So that means that would be pretty serious. So, and this was to tactile, visual, and auditory stimuli. So touching, seeing, or hearing things are causing her to freak out, basically. So there was a full range of extraocular eye movements with associated ocular-facial synkinesis, and I wouldn't be able to tell you all what this means. She also had saccadic eye movements. They were interrupted by ocular flutter and prominent convergent spasm with meiosis on visual fixation. So, one, she was alert and oriented to place, but not time, day, or year, and was only able to follow single-stage commands. So she was alert and was able to orient herself in space, but she wasn't able to orient herself in time. So she had a non-fluent aphasia and difficulty repeating sentences. So aphasia is the inability to speak properly. So she had perseveration, echopraxia, and marked mirror movements. These were perseveration, echopraxia, and marked mirror movements were evident on motor testing, but constructual apraxia was absent, so I wouldn't be able to tell you what all this meant. So they did some testing on her. They did the PCR test, and she was positive for SARS-CoV-2. They did the chest X-ray, demonstrated the bilateral peripheral pulmonary infiltrate. So the chest X-ray also showed SARS-CoV-2 like symptoms, and then some of the biomarkers were also indicative of SARS-CoV-2. So they also had an MRI of the brain, and the cerebrospinal fluid examination showed a white cell count of this, which is much less, or I should say that is within normal range. So it seems 0.001 times 10 to the 9th per liter versus 0.005 times 10 to the 9th per liter, which is the normal range, or less than that is within the normal range. A normal protein and glucose matched oligoclonal bands in serum, cerebrospinal fluid, and the standard cerebrospinal fluid neuroviral PCR panel, and the PCR for SARS-CoV-2 were negative. So the virus was not present in large enough concentrations to be detected in the cerebrospinal fluid. So they did extensive antibody screening, including the N-methyl-D-aspartate receptor, and so this is an example of a if you have antibodies against this particular receptor, it could be indicative of types of neurological conditions. Same thing with glutamic acid decarboxylase, or GAD, the contactin-associated like protein 2, or Caspr2, leucine-rich glioma inactivated 1, or LGI1 antibodies, ganglioside antibodies, and a panel of antineuronal antibodies in serum and CSF were negative. So she was not showing autoantibodies against any of these receptors, which are normally associated with some neurological, or what would be neurodegenerative diseases. Anyways, anti-glycine receptor and anti-peptidase-like protein antibodies were negative as well. So, the CT of the chest, abdomen, and pelvis confirmed lung changes, but no evidence of malignancy. The electroencephalogram was within normal limits with no cortical correlates to the myoclonus. Yeah, I don't know exactly what this is, but basically the brain scans were not associated with the myoclonus that she was experiencing. So let's see. So the patient was discussed in our multidisciplinary teleconferencing meeting, and as the most likely cause of her neurological syndrome was felt to be a post-infectious immune-mediated encephalitis, which is a decision, and then because of that, they made the decision to treat her with corticosteroids, because corticosteroids will help suppress the immune system, and the suppressing of the immune system will help suppress the autoimmune disease. So 14 days following onset of neurological symptoms, she was commenced on intravenous methylprednisolone, which is a type of corticosteroid, if I am remembering. I wish Wikipedia was Wiki. Yeah, so it is a corticosteroid, and so here you can see the typical steroid structure of it. So she was given methylprednisolone 1 gram per day for 3 consecutive days. This is followed by oral prednisolone with a plan to wean this to cessation over a period of 4 to 6 months. So following initiation of the corticosteroids, there was a slow, progressive improvement in her neurological symptoms, and on discharge from the hospital, she was able to mobilize with 1 stick, and cognition had returned to her previous baseline, so her cognitive ability was restored. There was ongoing fine myoclonus, however, and this was continuing to improve. So in this case expands on emerging literature describing post-infectious immune-mediated neurological sequelae affecting the central nervous system in patients with COVID-19. While causation is difficult to prove, the temporal profile of symptoms developing 1 week following COVID-19 clearly implicates viral infection as a contributing factor. So while we could not identify evidence of inflammation on neuroimaging, this is not uncommon in other forms of autoimmune encephalitis. So frequently, autoimmune encephalitis, you cannot see it with neuroimaging. So this is why we're trying to spend so much resources in trying to find out what biomarkers can be associated with neurodegeneration, because oftentimes you can't even see this neurodegeneration in the MRI scans or these X-ray scans. So I don't know if we really do X-ray scans of the brain, but the MRI is definitely, it's very difficult to get the resolution necessary to see the degeneration of the neurons. So we're putting a lot of effort into trying to find out what types of chemicals can be detected in the blood or the central or cerebrospinal fluid that could give us a clue as to whether or not someone has brain damage. And so there is a lot of work being done for professional sports, because in professional sports, people's brain, they can get concussed multiple times, and this can cause the degradation of the axons of the neurons, which could lead to CTE and other types of neurological conditions. So yeah, they're saying if you have this autoimmune mediated form of neuronal degradation, then you might not be able to see it in an MRI. So, but however, the prednisolone, these corticosteroids were beneficial at suppressing the immune system and then returning her back to her baseline. So granted, it could be placebo, or she could have healed without it, but they are describing it as if this was actually directly beneficial to her recovering. So although it is unclear whether treatment with steroids was a contributing factor to her improvement, or whether this was part of a natural history of her illness, this case highlights a possible role for steroids in patients where a post-COVID-19 autoimmune encephalitis is suspected after exclusion of appropriate mimics. So resolution of fever and respiratory symptoms together with repeated negative SARS-CoV-2 PCR and normal lymphocyte count reassured us she was no longer actively infected and made us more comfortable in starting corticosteroids, rather than considering other immunomodulatory options like intravenous immunoglobulins or plasma exchange. So some immunoglobulins can, help suppress the immune system by binding with certain receptors on these white blood cells and convincing them to kill themselves. So she said the repeated negative SARS-CoV-2 PCR and the normal lymphocyte count, so these are blood cells white blood cells that are associated with the lymphatic system, these, the counts of them indicated that there was no more ongoing viral replication, or at least not to a large enough degree to necessitate using a different type of immunomodulatory treatment. So, but remember, these neurological conditions were associated, how do I phrase that? Even after she healed from the SARS-CoV-2, there was still these, what would the word be? These sequelae, or these sequels of complications that she was experiencing. And so we need to be mindful that this may be happening to a large degree in this woman, but you might have a lot of other people in this world might be experiencing an autoimmune disease right now and not even know it, because it can take a long period of time before an autoimmune disease ends up resulting in pathology. So remember, these are progressive diseases. These are diseases that can get worse and worse over time, because this woman probably had a head start to showing these symptoms because she had a history of Alzheimer's. And so with Alzheimer's, there's already the presence of a lot of autoimmune antibodies that are associated with Alzheimer's. So perhaps the introduction of SARS-CoV-2 had caused the upregulation of some of those autoantibodies, or perhaps producing new autoantibodies that all work in concert to cause this damage on her brainstem. So it is of great importance for us to be very cognizant of how many people might be experiencing neurological sequelae, even if they were able to resolve the virus without dying. Okay, so fears that I have is that in the future we might experience higher levels of, say, multiple sclerosis or Alzheimer's or Parkinson's disease because we allowed this virus to sweep through the entire world without trying to control it. We literally gave up and said, let's go for herd immunity. If we let that happen, we might experience a lot of people that have these neurological complications, and we won't be prepared for it. This is one of my fears, and so this is why I'm trying to bring some attention to the possibility of having a huge autoimmune epidemic is what I'm seeing happening soon. So hopefully this does not come to pass, but I am not given a lot of confidence right now as far, I'm not given confidence that this won't be happening in the future. So with that, I'm going to head on out. Thanks for watching, and hopefully I can get another video out by the end of the day. So have a good one.